All right, let's jump right in. We're doing a quick, clinically focused breakdown of delirium, and this one is specifically for us, for pharmacists. We're going to cut right to the chase, what you need to know for recognition, medication management, and most importantly, patient counseling. So here's our roadmap. First, we'll nail down what delirium is and why it's so urgent. Then we'll put on our detective hats to find the cause. After that, we'll hit the most important part, prevention. Then we'll cover when and how to use meds for agitation. And we'll finish up with a solid action plan you can use every day. Okay, section 1. So what exactly are we talking about when we say delirium? The single most important thing to get is that this isn't a slow decline. It's an acute crisis. It's a medical emergency. The definition really tells the whole story. I want you to lock onto 3 words here. 1. Acute. This happens fast, over hours or days. 2. Reversible. This is key. If you can find and fix the cause, you can often reverse the delirium. And 3. Fluctuating. The patient can be lucid 1 minute and completely confused the next. It comes and goes in waves. And let's be crystal clear about this. Delirium is a massive red flag. It means something is going very, very wrong in the body. If you see this in the community, that patient needs to be evaluated immediately, almost always in a hospital. This is not a wait-and-see situation, it's a get-help-now situation. Now here's where it gets tricky. Delirium kind of has 2 faces. We all picture the hyperactive type, right? The patient who's agitated, pulling at lines, maybe yelling. But there's another kind, the hypoactive form, and it's the sneaky one. The patient is quiet, sluggish, lethargic. It's so easy to mistake this for depression or just being tired, but it's just as dangerous and it's missed all the time. Okay, on to section 2. Once you suspect delirium, it's a race against the clock to figure out why it's happening. And this, right here, is where we as pharmacists can be absolute superstars. To make sure nothing gets missed, there's a really handy mnemonic that clinicians use. It's called I Watch Death. And yeah, I know it sounds pretty grim, but it is an incredibly effective checklist for running down all the potential culprits. And as you can see, the list of potential triggers is huge. You've got everything from UTIs to withdrawal from alcohol to low oxygen. But I want you to focus your eyes on the second T, toxins or drugs. This is our playground. Medications are one of the most common and most fixable causes of delirium. And here's the rogues gallery, some of the absolute usual suspects. Anticholinergics are a massive one, from prescription meds all the way to OTC sleep aids. Benzodiazepines, of course. Opioids. Even things you might not think about, like H2 blockers. Your job is to be the medication detective, to scan that med list and ask, can we switch this H2 blocker to a PPI? Can we reduce that opioid dose? This is where you can save the day. Moving on to section 3. Finding and fixing the cause is great, but what's even better, stopping delirium before it ever gets a chance to start. And the secret weapon here, it doesn't come in a pill bottle. The evidence on this is rock solid. The best way to prevent delirium is with a bundle of simple non-drug interventions. We're talking about basic things like making sure the patient is hydrated, that they're getting up and moving, that they have their glasses and hearing aids so they're not sensory deprived. And for us, a huge one on this list is avoiding polypharmacy. Every drug you can safely remove is a win. Now, this is a critical point. The evidence just isn't there to support using drugs like antipsychotics to prevent delirium. It doesn't work. Prevention is all about good, supportive care. It's not about prophylactic prescribing. All right, section 4. So you've done all the right things, but sometimes a delirious patient still becomes severely agitated. They're a danger to themselves or to the staff. This is the only time we should even start to think about reaching for medications. So what's the line in the sand? When is it actually necessary to use a drug? The rules of engagement here are incredibly strict. A drug is an absolute last resort, only for when there's a real risk of harm. And remember this, you are not treating the delusion. The drug doesn't fix the underlying problem. All you're doing is managing dangerous agitation. So the mantra is lowest effective dose, shortest possible time, and stop it as soon as the delirium resolves. Okay, let's talk drugs. The main players here are antipsychotics, and it's all off-label use. The first thing to notice, look at those geriatric starting doses. We are talking tiny amounts. Now for counseling, you gotta know the side effects. You see haloperidol, your brain should scream EPS and QTC prolongation. You see olanzapine or quetiapine, think about heavy sedation and anticholinergic effects, which can actually make the confusion worse. That's a big reason why olanzapine is generally a no-go in older adults. And this brings us to what might be the single most important medication point in this entire talk. Antipsychotics and benzodiazepines are not interchangeable here. In fact, it's the opposite. Antipsychotics are what we use for agitation. Benzodiazepines, you avoid them. They are like gasoline on a fire. They almost always make delirium worse. The only, and I mean only, exception is when the delirium is caused by alcohol or benzo withdrawal. That's it. Okay, let's pull all this together into our final section. What can you actually do at the pharmacy counter tomorrow to make a real difference? Here you go, a simple 4-step plan. 1. Scrutinize every single med list that comes across your desk. Hunt for those high-risk drugs. 2. If an antipsychotic is being used, you need to counsel the family on what to watch for. Tell them about sedation, the risk of falls, and signs of EPS, like tremors or restlessness. 3. Hammer home the point that this is a temporary fix. These meds need to be stopped. And 4, always be an advocate for the non-drug stuff. That's the foundation of great delirium care. So I'll leave you with a question to take back to your practice. The next time you're on your shift, look around your pharmacy. What's that one drug sitting on your shelf? Maybe it's an OTC sleep aid with diphenhydramine. Maybe it's an old-school anticholinergic. That's the hidden culprit, the sleeper agent, causing delirium in your patients right now.